Welcome back to the Hand to Shoulder Solution, giving pain the middle finger. I'm your host, Carl Petitto. I'm an occupational therapist and a board-certified hand therapist. I specialize in the rehabilitation of orthopedic conditions affecting the fingertips through the shoulder. So anything dealing with the bones, the muscles, the tendons which connect muscles to bones, the ligaments which connect bone to bone, and the nerves. I've been practicing since 2000. I want to bring you this podcast because I want you to understand the fundamentals of how your body works and to recognize what your body needs so that you can obtain what you need when you need it. In healthcare, in general, the service that you obtain and the timing when you receive it is very important for a good outcome. So, with most things, the sooner you get to it, the sooner you address it, the better. And most things in life, of course, as we know, just seem to get more complicated the longer they drag out. What this is not treatment or advice. This is information sharing that you may be empowered to make decisions for yourself in accordance with your healthcare provider. Now, let's talk about carpal tunnel syndrome. It's become sort of a buzzword. I have carpal tunnel and my wrist hurts, my fingers hurt, I have numbness and tingling, or, I'm having some aching. Is a carpal tunnel. And there's some hallmark symptoms that I want to talk about. But first, let's talk about the structure and what does it consist of? What structures in the wrist and hand and arm are involved? Why are they involved? How do we figure it out as clinicians? Is it carpal tunnel syndrome? Is it tendonitis? Is it a strained ligament? Is it tight muscles that are putting excessive tensile stresses on their origins and insertions? Is it et cetera, et cetera, et cetera? So let's talk about the carpal tunnel. Now, we all have a carpal tunnel, and it's made up of the carpal bones, and there's 8 carpal bones. Roughly, there's 2 rows of 4 bones in the wrist. But let's talk about the wrist, starting with the elbow, working our way through the forearm. At the elbow is the end of the humerus, which we know that's our arm bone. So we have the arm and the forearm. So we have the humerus that comes down and meets the radius on the thumb side and the ulna on the small finger side. The ulna always stays stationary and does not rotate. The radius rotates or spins. So when you're palm up, and this is the right hand, when you're palm up, the radius is parallel with the ulna. When you turn it palm down, the radius flips over the top of the ulna. At least it's supposed to. Let's get the model to do it here. So the radius flips over the top of the ulna, just like that. Now when it turns back palm up, now the radius is back parallel with the ulna. Now, when you go off the end of the radius, moving toward the fingertips, you have the first row of the carpal bones. And you have your scaphoid bone and the lunate bone. And then you have your triquetrum and pisiform, the hamate, the capitate, the trapezoid, and the trapezium. Trapezium at the base of the thumb. And those bones, when they're all assembled and held together by ligaments, bones are connected by ligaments, muscles are connected to bones by tendons, okay? So the ligaments make them form sort of a concave shape when you look down onto your palm. So the heel of your palm, if you follow your thumb down, you have the base of your thumb, and then you go across your wrist, that's the carpal tunnel right here. And then on the end, you have this round bone, sort of like a pea shape, the size of a pea, and that's your pisiform right there, all right? Over the top of that is a thick, heavy ligament. And let's see if I can get something just to show. There's a thick, heavy ligament that goes over the top, and that forms the roof of the tunnel. So why is there that tunnel there? That the tunnel is there because that allows passage of the tendons which connect your muscles in your forearm to your fingers, to bend your fingers. Now, muscles only contract. They don't push. So muscles only pull. So when these on the palmar surface of your forearm contract, they bend your fingers and your thumb. On the opposite side, on the back side of your hand, the back side of your forearm, when they contract, they open your hand, your fingers, and thumb. All right. Now, it's very interesting that there's two tendons because there's two muscles. There's two tendons to every finger, your index, long finger, ring finger, and small finger, because they move different joints. And that's how our grip can be so strong. So the tendons that go through the tunnel, there's two to each finger, index through the small finger, so that's 8. And there's one that goes through the tunnel that goes to the tip of the thumb that makes 9. So 9 tendons. And the tendons are pretty big. They're about the size of probably a linguine, a wide flat noodle. All right. And another key structure which causes the symptoms is the median, median nerve that also goes through the tunnel. So picture this. We have 9 tendons, okay, all going through the tunnel and the nerve. And remember, there's that thick, heavy ligament on the palmar surface which forms the roof of the tunnel. It's called the flexor retinaculum or the transverse carpal ligament. So we'll misuse our hands by, hitting a chisel or hitting the end of a screwdriver, or if we want to slide a board a little bit, we'll use the palm, the heel of our palm, so to speak, to push that. That's smashing the nerve. So when you cross your leg and your foot goes to sleep, that's because of pressure on a nerve. That's not decreased blood flow. It's pressure on a nerve. And when you kink off the nerve, it causes a numbness and tingling and also a deep ache. Now, what I talked about on past episodes is the nerves are a wiring system for our body. So we have motor and sensory. So the motor nerves literally plug into the muscles, and our brain sends an electrical signal through the nerve, through the wire to the muscle, and it causes a chain chemical reaction for the muscles to contract, pull on the tendon, and move the skeleton. Okay, so it starts with the brain, central nervous system, spinal cord, central nervous system, and then it goes into the peripheral or periphery outer nervous system. So central nervous system, and then it turns into the peripheral nervous system. It comes out of the neck. All these wires or nerves go through the brachial plexus, which is through the armpit area, or the axilla. It goes through the armpit area, and then they branch out. So if a person is having numbness and tingling, let's say on their little finger side, or the little their little finger, or the small finger side of their ring finger, then we know that that's going to be the ulnar nerve, and those go through different structure. The ulnar nerve passes through different structures. If a person is experiencing numbness and tingling and aching through the thumb side of their hand, the thumb, the index finger, the long finger or middle finger, and the thumb side of the ring finger, or some of those and not all, then we know it's the median nerve. And the median nerve goes through, among others, the carpal tunnel. So there's basic tests that we can do in the office to see if it is being pinched off in the carpal tunnel. But why does it get pinched off in the carpal tunnel? Let's talk about that first. So carpal tunnel syndrome, we now know it's the median nerve, and it's being pinched off in the carpal tunnel. We'll talk about how do we figure that out? How do we diagnose that? We'll talk about that later. But it's being pinched off in the carpal tunnel, and it's affecting the thumb, the index finger, the long finger, and half of the ring finger. The symptoms are numbness and or tingling, prickly feeling, deep aching. Also, at night, the nerve gets pinched off in this small tunnel where there's 9 tendons passing through. And let's say, maybe a person sleeps like this a lot, or they sleep like this a lot, and it's putting excessive pressure in the tunnel. Or I'm working construction, and I'm hitting things with the heel of my palm several times, and it's causing trauma to the nerves and the tendons and the bones. anything that occupies a space in the tunnel puts pressure on the nerve. So that's, if you think about those mechanics, if you have swelling there because now you've been hitting the heel of your palm on things, or you fell on your wrist, or arthritis is causing, some swelling, it's causing inflammation, and that's taking up space inside the tunnel and choking off the nerve. A lot of people also think about typing a lot with the carpal tunnel syndrome. It used to be thought of more so, in the past about, frequent typing causing carpal tunnel syndrome. I think, poor ergonomics or poor workstation setup or poor biomechanics, how you're using your body, really causes carpal tunnel syndrome more than just the act of typing. But, let's talk about that. Frequent movement of the fingers, getting the tendons sliding in and out of the tunnel, sliding, and then getting irritated, getting some tendonitis. Remember, itis means inflammation. And again, that could take up space within the tunnel and also pinch off the nerve, because remember, all these structures are packed into this tight little area. Now, let's talk about a wrist rest at the keyboard when you're typing. If we have the movement of those tendons gliding through the tunnel, back and forth, gliding through, gliding. Now, what I do not want to do is I do not want to rest my wrist on a pad, because now it's resting on a pad. I'm typing for hours, right? Now, this is where the ergonomics comes in. Now, it's a friction point. There's more friction. The tendon is rubbing harder because there's physical pressure there. I want to get rid of that wrist rest. The ideal situation is to pull the keyboard up to the very edge of the desk. So now you're typing with a pretty straight wrist, okay? And there's nothing but air on the carpal tunnel. There's no pressure there to increase friction. And it's not going to be irritated as much. And the shoulders, the chair is high enough so it doesn't have to be up like this where your shoulders are up and now it's bothering your neck and maybe pinching the nerve up higher now. You can relax, have the elbows bent at about, 90 degrees or 80 degrees, a little bit less, just a comfortable position to where the wrists are pretty straight. There's nothing but air in the carpal tunnel, and you're not in a forward rounded position. You're up nice and straight and comfortable. The screen, the center of the screen is about level with your nose, so you're not cranking your neck either way. There's a lot of ergonomic considerations, and we can get into those on a separate video, but at least understand this. If you don't want to rest your wrist on anything while you're typing, it also goes with the mouse. And I don't want to get off topic, but the ulnar nerve goes through a canal next to the carpal tunnel called Guillen's canal. And just real quick here, there's that little bone here. There's this little, there's a little area here where the nerve can pass through on this side, and that innervates or plugs into the little finger and half the ring finger. And using the mouse, and you're resting on that area, what's nice to do here is to maybe have that mouse forward a little bit and have a rolled cloth or something underneath the forearm, muscles of the forearm. And now there's nothing but air on your wrist when you're using the mouse. All right. So we'll get into that on a different episode as well. So that's basically what's happening inside the carpal tunnel, is that something is occupying space, things are aggravated, the nerve has pressure on it. All right. Now, we talked about earlier, the nerve comes out of the spinal cord, goes through the armpit, goes down the arm. It's important to note that there's several other tunnels or areas that it passes through along the way where it can get pinched off, and you still have exactly the same symptoms as carpal tunnel syndrome. And this is called differential diagnosis. What's the differential, or what else could it be? So it's really important that we get to the bottom of it and rule out other things, so we know exactly where the nerve is pinched off, because we need to treat it. We need to treat it where the problem is, not necessarily where the symptoms are. So even if it is within the carpal tunnel and you're feeling symptoms in your fingers and in your hand, we're not going to treat that area. We have to treat the wrist if it in fact is being pinched off at the carpal tunnel. Now, one way to determine that is there's a combination of things. So in the office, we'll do things like Tunnell's test to see if tapping on the nerve sends a zinger down the distribution of the nerve. Do Phelan's maneuver and see if compressing the nerve at the carpal tunnel lightly does light it up or make the symptoms worse. That's called a provocative test. Does that provoke the symptoms? And then all that tells us is that we're getting closer. Something more definitive is electromyogram or nerve conduction study that typically folks would go to someone who's trained to do those, and where an electrical current is set through the nerve and it's measured. The speed of the electrical current is measured, and it can be found where the speed is slowing down. That's where the nerve is compressed, so we can get a much better detail on the location of the compression. So what are different locations? So there's the cervical spine or the neck. You could have your nerve being pinched where it's coming out of your spinal cord between your vertebrae. There's Struthers ligament or ligament of Struthers at the end of the humerus, your arms. Remember, you have your arm and forearm, so the end of the arm, and where you have this the front part of your elbow, usually where they take blood, that area, there's deep, thick ligaments in there. We can go into greater detail on another podcast where that nerve can be a little pinched off. There's Lacertus fibrosis syndrome, pronator syndrome. There's a muscle called the pronator teres that pronates the forearm. So that muscle travels from the inside part of the elbow, the small finger side of the elbow, over to the radius. And when that contracts, it turns the radius over the top of the ulna. In other words, turns your hand palm down. And that region, that area right there, is another pinch point for the median nerve. So I want the public to have a general understanding of, you could be having symptoms of carpal tunnel syndrome, but not have carpal tunnel syndrome. It could also change the treatment. Do you need surgery? There's a lot of factors there that we can talk about in this episode. Can you get away with not having surgery? Can you get this treated conservatively or without surgery? And I want to talk about some of those techniques. So how is it treated? Let's talk about without surgery. Me as a hand therapist, I ask my patients, okay, what do you do for work? What do you do for hobbies? What are your symptoms? Of course, where are your symptoms? What time of day are they happening? How intense are they? Is it just numbness? And I'm going to test that numbness. I'm going to compare it to the opposite side. Is it numbness and tingling? Is it deep aching? When did it start? So, one thing to always be mindful of before you go to your doctor or to your therapist, when did my symptoms start? And then you're also going to be asked, since this began, has it been getting worse? Has it been getting a little bit better? Or have your symptoms largely been remaining the same? And this is really going to help us as providers really do what we call clinical reasoning. So we're the whole time we're interviewing you, we're figuring out what is the best course of treatment for you. So let's say, and again, I want to remind everyone that the sooner you catch something, the sooner you get started with treatment, the better, and the quicker you're going to get rid of the condition. And that's especially the case with carpal tunnel syndrome. Now, I occasionally have some people come in and they've been dealing with this for, a year or 2 years. Just let's have the go get the testing. If it is carpal tunnel syndrome, just get the surgery. It's been going on for a long, long time. If it's been a few months, 3 months, sometimes even 6 months, therapy can help. So one thing we want to do is take pressure off the nerve. So one thing is to maintain the maximum diameter of the carpal tunnel. And what I would do usually is make a nighttime splint, a nice custom splint that would not have a stiffener bar. The over-the-counter braces that are, designed to fit everybody. There's some basic sizes, but every hand is so different, and most of them have a stiffener bar in them to keep the wrist straight. But the problem with that is the stiffener bar puts pressure on the carpal tunnel. And if the wrist is straight or even bent toward the palm a little bit, well, might not be too big of a deal. But the second a person starts to go like this, it just starts pressing into the bar more, putting direct pressure on the nerve. So in this instance, that brace is doing more harm than good. So what I'll do is I'll fabricate a nice custom thermoplastic or the plastic moldable material that would position the wrist in slight flexion toward the palm. We used to think that 30 degrees of wrist extension maintained the maximum diameter of the carpal tunnel, but most recent studies are showing that it's about 3 degrees or 5 degrees of flexion is maintaining the maximum diameter of the tunnel. So why is that important? If we maximize the diameter of the tunnel, then that's literally mechanically just taking pressure off of the nerve. So especially at night, if you tend to, sleep on your wrist and put pressure on it, or sleep with it way back, that's pinching it off. If you sleep with your wrist folded toward your palm, and that's pinching off the tunnel. So if we make a nice custom molded orthosis to keep that wrist in exactly the correct position at night, almost 100% of the time, patients can have a comfortable night's rest, and we allow the nerve to start to heal because now we don't have that pressure on there. And then midday and at the end of the day, cryotherapy technique of cold running water or direct icing, holding an ice cube and putting the ice cube directly on the skin right over the carpal tunnel. Again, no pressure. Ice is hard as a rock. You want to rub a rock on there, but just gliding the ice on the skin back and forth until it's deeply cold, 10 to 20 seconds, and cold shrinks. So the cold, just like with arthritis, like we talked about in the last episode, cold will shrink down the inflammation, reduce the internal swelling, and further reduce pressure on the nerve. Now, let's talk about nerve flossing. So we talk about how the nerve comes out of the neck, travels down the arm, goes through the carpal tunnel, branches out. We can get the nerve gliding through the structures it passes through to make it more healthy, more extensible, and just make the nerve happier. So we do, I have patients do it for, until they feel light, achy pull, 3 seconds, 1 and 2 and 3, put on slack, again, 1 and 2 and 3, put on slack, 3 seconds, 3 repetitions, 3 times a day, 3, 3, and 3. Ulnar nerve is, different positions, but that really helps a great deal. And then there's something called differential tendon gliding. So the tendons that go to the fingers, 2 to each finger, 1 to the thumb. Let me just show you real quick. So one muscle, when it turns the tendon, goes through the carpal tunnel, it inserts on that middle bone. The end of the tendon splits and it inserts right there on that middle bone like that. And that's called FDS, flexor digitorum superficialis. So below that, FDP, flexor digitorum profundus, the tendon goes through that split and inserts right on the tip of the finger. So if you hold your finger and only bend the tip of your finger, you are using flexor digitorum profundus, FDP. We abbreviate everything because these words are so long. So in the office, we can talk shop and it's quick, and we can just say, they're FDP and FDS, etc. Just different muscles. And then if you hold the big knuckle from bending, and you just bend your middle knuckle, then if you bend the big knuckles, like you're going to punch with your fist, those two are FDS. So that's how, one of the ways we can have such a strong fist is because we have two nice, big, strong, pretty heavy muscles. And you can see them here. The muscle's red and the white, it turns to tendon. And they travel under the carpal tunnel. The yellow is the nerves. So you see this nerve right here is the median nerve. It's actually a little smaller on the model than it really is in real life. And there's a lot going on here. I removed some muscles so you can see it better. When those tendons, we know where they are in the carpal tunnel. So if you go into different positions, then we're getting the tendons to glide differentially or separately from each other. And why is that important? That's important because what that's doing is that's shifting fluid and pulling fluids, out of the tunnel where it's probably swollen internally. And sometimes if that fluid is allowed to pool in there and hang around, it starts to get really thick and gelatinous. And then that, of course, puts all the more pressure on the nerve and gives the patient more symptoms. And so, and here we go again with, it's science and art, and that's why we call it practice. So the art of it is, what combination of things do we want to do for the patient? Another thing is, because everybody's situation is different and how they respond to treatment, everyone is different. Cold laser treatment, the penetrating the tissues with a bright red light to reduce inflammation and increase blood flow at the same time. Also, we can use ultrasound. So one thing that we do not want to do is massage the carpal tunnel. So you know what? If there's some internal swelling, well, why don't we just push it out? We can just massage it out. Well, then we're putting pressure on the nerve. Do not want pressure on the nerve because the syndrome it's a nerve compression syndrome, and that's what's causing the symptoms. Now, ultrasound, which therapeutic ultrasound is just like diagnostic ultrasound, except it's a lot more intense to have a therapeutic effect. So ultrasound is using sound waves to penetrate the tissues. So I can set the machine, and we use the gel just like with diagnostic, but we use water-based gel, so it makes a seal, and that seal focuses the sound waves to penetrate the tissues better. I can set it at the appropriate intensity. I can set it at the appropriate depth. So now I can glide over that carpal tunnel and penetrate the area with sound waves and kind of loosen things up in there to help the fluid leave the carpal tunnel without putting pressure on the nerve. So that's something that's pretty interesting, and that's a very good tool. So in combination of ultrasound, red light laser treatment, cold laser. We call it cold laser because it's not a hot cutting laser. So cold laser treatment, nerve flossing, differential tendon gliding, and wearing the nighttime brace, adjusting the workstation so we're not using our body wrong and further aggravating it. Now that would be therapy or conservative treatment without doing surgery. So now let's say, the patient comes in, they've been having symptoms of carpal tunnel syndrome for a year or something. Some of them, they come in, they've been having it 2 or 3 years, and now all of a sudden it's getting a lot worse. They have the nerve conduction study. We know it's not pronator syndrome. We know it's not the Lacertus fibrosis. We know it's not this. We know it's not the other thing. We know it's not from the neck because, they've been sent for all the right testing. We know it's carpal tunnel syndrome. All right. Now, what used to be done primarily for a lot of years is an open technique for opening up the carpal tunnel. So backing up a little bit, remember the thick, heavy ligament that goes over the roof of the carpal bones it makes the roof of the tunnel when you're palm up. That thick, heavy ligament, the surgery is to cut that, and now it opens up the tunnel, and it physically takes pressure off the nerve. So how do you get to it? So what used to be done primarily is to do an open technique, which is making about a 4 centimeter incision right over the transverse, right over the carpal tunnel, and opening it up all the way and cutting that thick, heavy ligament. The The newer technique now is to make just a small, probably 1 centimeter incision, proximal or closer to the going toward the elbow, just that little wrist crease right here, kind of just behind the carpal tunnel. And then this is really slick how they do this. So that thick heavy ligament, they'll make a little slit in the back, and then they'll pass a little video camera. So this is endoscopic, and they'll pass a little video camera underneath there and visualize it and make sure it's a clear path right underneath that ligament, because you can't nick the nerve or any other important structures. They eyeball it with the video camera and see, well, it's safe to pass another tool under there, which is a guide rod. It's actually, when the camera is under there, you can look at it and then you can manipulate the tool to raise up a tiny little blade. So when you pull it back, now what that does is it just severs that thick, heavy ligament that makes the roof of the tunnel. And there's your release. But now instead of a 4 centimeters wound and a 4 centimeter scar, you just have a tiny 1 centimeter scar just behind the carpal tunnel. And that is much less traumatic. It's an easier recovery. So speaking of recovery, most patients with the open technique, with the longer scar, should have a few visits of therapy following that, in my opinion. The closed technique, that usually do not need therapy after that. I'll get patients in the office who did have the endoscopic technique with just a little incision, because they were swollen and they were a little sore afterwards. So they went home and they were massaging their carpal tunnel, trying to get it to feel better. So they're rubbing it. Also patients who are just frequently moving, just like with arthritis, it's easy to make the habit of just moving it all the time and keep it moving, but that's the wrong thing, because that's gonna increase inflammation. And when you increase inflammation, you're gonna put further pressure on the nerve, especially when you're rubbing it. When you're rubbing it, you're right on the nerve, so you're actually rubbing the nerve, and that's going to bring the carpal tunnel syndrome symptoms back. They will return. So in the office, when they come in to see me and they're having these complications because they've been doing the wrong thing at home or doing too much of something at home, then I'll have them, of course, immediately stop the frequent movement, immediately stop the rubbing, which they shouldn't be doing in the first place, and then also just restore the health with some specific tendon gliding techniques, which we talked about earlier, some nerve flossing, the proper use of cryotherapy or cold. You don't want to wrap an ice pack around it, because now that's pressure on the carpal tunnel. But cold running water that envelops the whole wrist and whisks away the heat and penetrates nice and deeply, that reduces the inflammation very, very nicely. And then, of course, the ergonomic modifications at a person's workstation, regardless of what job they do. We want to make sure they're not leaning on their wrist, they're not overtaxing their wrist in the wrong way. Also, sometimes a person might have to have a brace, really short term, ideally something custom made to properly position the wrist, just to get things to calm down, and then immediately, wean off of that. So if you're feeling numbness and tingling in your fingers, what should you do? You should be seen by an orthopedic surgeon. So there's orthopedic surgeons and there's also hand specialists. So a hand specialist is an orthopedic surgeon who went on to further training, to usually with a hand surgery fellowship, to really focus on typically the wrist and hand, but basically they're an upper extremity specialist. Their title is a hand surgeon, a board certified hand surgeon. I'm a board certified hand therapist. I work with board certified hand surgeons. It's a specialty area that a lot of people don't know about. And it's just like if a person's having a heart problem, they go to a cardiologist, they're the specialist for the heart. So really with most wrist and hand conditions, if you can be seen by a hand specialist, that's really ideal. So thank you very much for watching. I know it's a lot of details. Write in with questions. contact me and get care, get treatment, get evaluated sooner rather than later. And that's what I'll end with, sooner rather than later. Thank you.